Good afternoon, everyone. So my name is Melisa Wilson, and I am a nurse practitioner who's had the honor of taking care of those living with pulmonary hypertension for the past 20 years. I work at Avon Health Orlando, where I am the pulmonary hypertension program coordinator and the advanced practice provider director this week for heart, lung, and vascular services. We'll see what next week brings. It is truly my honor to bring you all this conversation today. While it's called PAH Fire Chat, I love the renaming from Lori as the poolside chat because, we're in Vegas. And really what this talk today is going to be around is truly conversational. You have many, many opportunities to learn about pulmonary hypertension, how we treat it, the medications, which medication is right for your patient, when to de-escalate, when to escalate, all of those types of things. But what we often don't really get is that conversation that I feel like I've been very fortunate to be part of with my colleagues, talking about and exchanging the patient journey and how we help navigate them and support each other through that process of caring for this very delicate population. So before we dive into that component, I think it's important that you meet my distinguished panel here who's going to drive this conversation today. So start with you, Mindy.
Hi, everyone. I'm Mindy Rivera. I'm a clinical nurse specialist. I practice at the Cleveland Clinic. I've been in the PH space for about 10 years. Last year, I followed my dreams to diurese the world and moved over into the heart failure space. So my group 2 PH and HFpEFR, those are my homies. So glad to be here and share some of those experiences.
Hi, I'm Susie McDevitt. I'm a nurse practitioner at the University of Michigan, and I've been in PH quite a while. I think I'm 28 years, but that ages me, so we won't say that. And I just love this whole idea. Thank you for having us and just kind of talking about the whole person more than just always the medications and the risk score and the right heart cath numbers. And this is really important too, so thank you.
Hi, I'm Lori Reed. I'm a nurse practitioner at Piedmont Healthcare in Atlanta. I have been taking care of PH for roughly a decade, and I appreciate being included because these conversations are important and they happen every day. And so being able to have them with some ease is important.
Corinne Young, nurse practitioner. I'm in Colorado Springs. I've been in community practice in pulmonary medicine for going on 22 years now, and against my will, got into pulmonary hypertension when I joined my group in Colorado. And although group 2 is the most popular, we are group 3, like we are group 3 central because everybody's hypoxic. So, but love to be here. Excited to have a great conversation without like a ton of slides. That's always fun too.
That's right. That's right. Because, who wants to make slides? Not me. So, I'm going to start off with, let's hit it with the fun, right? Let's talk about sex, baby. Right. So when we talk about, pulmonary hypertension, again, like I said, this is a diagnosis, this is the disease, this is how we treat you, this is why you need a heart cath, this test, that test. And often in those conversations, the time that we usually bring up sex is usually to our female patients, right? And mostly we're not talking about sex. We're like, don't get pregnant. Pregnancy is high risk. It is not good. We don't know how you're going to do with pregnancy and PH, but we don't talk about the intimacy. We don't talk about what that connection's like. So I wanted to bring that up today and kind of talk about, let's talk about sex. When do you have that conversation? How long, before you introduce that, or who brings it up first? So whomever would like to share, you can start there.
Well, I'll say the ugly part first is that I don't do a great job of that. And I think a lot of us realize that too, that, in the competing priorities of everything that you need to fit into, if you're lucky, a 40-minute visit with your patient with severe PH, that, you've got education about your diagnosis, your meds, everything else. And so, other lifestyle things. And then this kind of comes at the end unless, your patient brings it up. So, I'm glad we're having this conversation to kind of practice through discussing and becoming more comfortable with these things, because the majority of us, there's just not enough time. That's the reality. And like you said, if we're talking with patients, it's usually female patients, and it's more of a no sex conversation than how to have sexual intimacy in your life once you've had this diagnosis.
Well, I was going to say, I had the privilege of attending the PHA intimacy session last week. I don't know if anyone in the audience was at those sessions, but I found it to be extremely informative and helpful. I love our community because we really share and lift each other up and try to make sure we're all taking the best care of our patients and share best practices. It was such an excellent session for every clinician, I think, if you get the opportunity to watch it. So some of the tips, can I share a couple of the tips? I think that, it's of course we have to build trust with these patients, just like everything else. And I don't think this is specific to our chronic illness. This is specific to many chronic illnesses. But intimacy is such an important thing to be thinking about, that our patients are thinking about. So they had some nice tips on how to kind of bring that up. And some things were, first of all, there were many women in the audience talking about body image when our patients have infusions, of course. So IV Hickman catheters and subcutaneous and oxygen. And boy, oh boy, just listening to them share their stories of their body image and how difficult that is with a partner is pretty humbling to hear. So talking through that, and they say they kind of work through that to get past that as a first step. They talk about their partners being scared to death to touch them and feel like they're like a China doll because they have this very severe diagnosis, how ill they feel with medications, good days, bad days, all the things we already know. And then there were people talking about, checking in with your patients on, we're always checking in with every visit. We want them to get back to normal life. Are you walking in a grocery store? Are you doing things with your family? And so there was a clinician, it was Dr. Jim White, who shared, he always asks the 4 S's, especially patients on pumps, but, sex, swimming, sleeping, and showering. And that's pretty good. That's a pretty good way to think about it. How are you showering? Is that going okay? Intimacy, sleeping with these pumps and medications and all those things. So that was kind of a nice tip. They had a lot of tips physiologically. I'll hold off on what you can say to your patient. Patients talked about, and we've heard this, am I going to die during sex? Am I going to have a heart attack during sex? They can't differentiate all that. These are such real fears. So anyway, they had a lot of good tips. I won't keep talking. I'm going to open up to these guys, but it was an excellent session. And we felt as clinicians, we learned a lot on how to kind of approach this.
Gosh, that's wonderful. And I feel like I'm blushing now. And so when I have these conversations with patients, I do blush. But then I also think that maybe I can be an actress and get over it, right? Like we put ourselves aside so that we can provide them what they really need. In my clinic, it's usually the guys that bring it up naturally and first. And they have questions about like, what's going to happen if I do, because they don't want to scare their partners, right? So we talk through that. And then with the ladies, of course, we talk about the same kind of things, but then that also curtails into the pregnancy talk, which sometimes sidelines really what we're getting at here. But we talk about trying to schedule some of that intimacy time with their partner, which without a chronic condition and being married for a long time, you have to work on your marriage. And usually part of that is scheduling time together. And so I try to talk to them about like, that's just normal life. You've got to schedule your intimacy time and your time that you set aside for each other and take everything else away. And so I ask them to kind of trend when they feel best and worst with their medications. And so what time in their calendar would make them feel the best to schedule this time with their partner and, let them know that it's natural to have to schedule time for this.
That was a big comment at the meeting, was normalizing it, that actually, all relationships go through ebbs and flows of intimacy challenges, and just to normalize it, so that was really great.
I think being a female provider, it's a lot easier talking to the female patients about it. And it usually starts with the medications that are teratogenic, and then also issues with, high risk if they do become pregnant. And so then just leading that on to the discussion of sex. And again, I feel very, I'm non-blushy about it, but my kids, it drives them crazy. They're like, stop talking, stop saying those words, so, and they're like 25 and 19, and they're like, it's my job to embarrass them. So, but like the female patients, one of the things I talk to them about is sometimes even changing their roles in sex. Like, you are now the princess. You should not have to do as much work because that might just be easier on you. They kind of giggle a little bit, and that kind of opens the door for us to talk about a little bit more. With the male patients, usually because I'm at high elevation, a lot of our patients are on oxygen therapy very, very early in their disease. And so we talk about titrating their oxygen for exercise. So I start with just kind of like, we're going to do this walk test for you. We're going to titrate your oxygen for walking as well, and what it needs to be at resting, and monitoring their numbers. And so then I'm like, so when you're doing anything that gets your heart going, and then I'll and if they're still not picking it, I'll just kind of slowly get into it. I had a male counterpart physician who was managing our PH patients, and I would also encourage him with the male patients to go a little further in talking to them about sex, because sometimes they just weren't as comfortable talking to me, just depending on the feedback I was getting to them as we were talking about what they were doing. And I think also what has helped me talk a little bit more about sex with male patients has been sotatercept. There's potential for fertility issues. And so I've actually started, mentioning sperm banking, to some of these patients if they're younger, and, this may be consideration. Or do you want to have children? Do you have children currently? This could be something you might want to do and consider. And then that kind of leads into a sex discussion, also. But the concern of dying during sex is, I think it's their number one fear. Am I going to die? And their spouses, if it's not the patient's fear, the spouse is so worried that they're going to be ultimately responsible for their demise. So it's great when spouses come, because you can have a conversation with both of them. And oftentimes one of them is going to be a lot more open to talking about it than the other. And sometimes it's the patient who's just like, stop talking also. And then, but the spouse wants to know, what can I do? What can I do? And, is that even an option? So.
Can I give a couple tips? I know we probably have to move on topics, but
Go ahead.
these were some of the tips that I thought were really helpful. Obviously, position. And so they talk about don't ever be in a position that you have a lot of pressure on your chest. And we're all talking about this to make it better for our patients. Or kind of using your upper body and arms. So that was number one. Number two, have a signal, a safe signal. I think this is great for teaching patients, tap, tap, tap. Stop, something. They had a lot of just basic tips that I thought, this is really an untapped area that I need to do better. We all need to do better. It's a time thing. It's not because we don't care, right? It's time. But it's such a blessing when they're in the hospital. I have so much more time to talk about contraception and all the things than a clinic visit.
So I guess I'm not the lucky one, because the patients sought me out. In fact, one day they were like, hey, we want you to do a support group on sex. And I was like, of all the human beings, you picked me,
I'll have a slide deck on that.
We'll work on that. And why it occurred was because often I would bring it up to the patients, right? So you observe these couples, and I would like to get to know who my patients are, right? Who were you before you were a PH patient? And so a lot of my older couples, sometimes I'd be like, they bring in your wedding pictures, show me who you are, and they get really excited about that. And I would often say, I see that relation between you guys, the love between you. And so how are you guys connecting? And they're like, well, I'm helping her with her meds, and I'm helping him. And I'm like, yeah, but you can still connect, right? Y'all can still connect. And I'm like, and it's always, ooh, really? We can? Yeah, you actually can. And we talk about things like you mentioned the pump. One of my patients, what she used to do, she said she used to take her old t-shirts, she'd cut them up, sew a pocket inside her pajamas so that she can have it attached on her upper body while the rest of her was free, so that she did not have to worry about the weight of the pump through the intimacy, through intercourse. They liked really just having that space to say it's okay to mention it. Often the partner just feels relieved. And then I also have had people they're the young ones, the ones who just crossed over into adulthood, and mommy comes to the appointment. and says, "Hey, this was one I love. This patient, her came in with her mom, and her mom's like, oh, she's going on this like trip with some friends," and I was like, really? So she's like, yeah, she doesn't do that. I was like, yeah, I bet she's tried, right? And she was like, no, she doesn't do that. And I was like, hey, mom, it's time for you to go. And so it's like, she was like, why? I'm like, because she's 19 and it's time for her big sister talk. And sure enough, the patient sure had already tried, right? And she has a congenital heart defect on top of it. So we really need to talk about like, oh, so what did you do to make sure, like when you were attempting this, that like that you would reduce your risk of pregnancy. We talked about everything, including vaginal dryness, which she was experiencing from the medications that she was on. We talked about positions. We talked about what it means to be like safe. So just know that sometimes if you feel that person may not be comfortable, sometimes you can have it together, and other times you may need to be like, it's time for you to leave the room. And then when I left the room, then Dr. Tarver came inside to have the dad talk with her, and he did. He brought up the no means no, kind of conversation, and she really felt a lot better. Her mom was like, well, what happened in there? I'm like, we talked to her about it. Well, I did what I was supposed to do. I told you I had a big sister conversation. So it really is important, and the relationships that you build from that really strengthens. And I guess they must have shared it among themselves as a support group, and that's why they asked me to do this talk. And I was like, please don't make me talk to all of you one time about this. But it really is something that I would encourage that you actually do make part of the support group conversation, something that you do really be intentional about. We know that we start these medications and we're like, oh, don't get pregnant. Or if you do, here's what happens. Here's how we've had those conversations, but really talking about what it takes to get pregnant, we sometimes leave that part off. So, you'll find the right time, but don't let it go too long, because inside what's happening, and there has been some studies around how the partner feels, and they feel like they become their roommates. They feel like they've just become their healthcare provider. They forgot what it means to have that intimate connection. So
let me tell a funny story that just happened the other day. I had a 72-year-old come in with her spouse, and she has all her testing that day. And I said, and sometimes I'll say, you are A+ today. Everything's A+, everything's at goal. And he said, did you hear that? Did you hear that, honey? That we're still once a month. We're blah, 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 blah.
Right.
I said, absolutely. No contraindication.
Yes,
That's
that's
very
right.
cute.
I'm changing your script to twice a month.
My other one
looks great.
I also love the other one when they say, oh, these meds, they don't really work, but that at Circa, I don't need it, but I need it. Right. So I'm like, you can keep it. No worries. So it really is, you have these windows that you can bring them up, even when you are like PD5s, I found used to be a great window for that conversation. Even when it's for the female patient, I would always look at her husband, be like, this is for her, not for you. So it's not one for her, one for you every day. Right. So just use those windows to really kind of, just like you said, you build that trust. You also let the patient realize you see them as a whole person. So, maybe I should have made that part second, because the next part of the conversation is kind of talking about a little bit more of the opposite side of it. Yet, if you really understand what palliative care is, you understand that palliative care is not talking about end of life. We understand palliative care is about living with PH and us managing your symptoms and us managing you as a whole person. But I think often when we talk about palliative care, patients are intimidated, and we are as well as providers. So I wanted to talk a little bit about like, how do you, when do you really address that conversation around that symptom management, palliative care, and even that end of life discussion with your patients? How early do you bring that discussion into your care?
First visit for me. And that's my COPD years. That's any of my chronic lung disease, my ILD patients. I always tell them I want to have this conversation now. And I even talk about hospice too, like what that looks like and when, and the difference between the two, because they often associate both. But I bring it up very, very early about quality of life, and even with, and I also say, like, I am so hyper-focused on your pulmonary system. Palliative care is caring about head to toe. Literally, you've got foot pain, they're going to want to help you with it. But I'm so hyper-focused on this. I don't want to miss anything else. And they're going to be this resource for you. They come to you. It's not another appointment. They come to you. They help you in the space. They evaluate your home life and what can they do to help you there. Do you need a shower chair? Do you need a chair lift? Do you need a bed? Some things that we're not privy to in their home that's happening for them. I do want to go back just a little bit to the PD5. Sorry to keep it on sex, but
Sex is fun.
I know it is.
Fun topic.
Fun
Excuse me.
topic. Well, I think we've always had bias about those drugs with men, right? And I think that's another reason we don't talk to them about it. We're like, you're on sildenafil 3 times a day. I don't need to talk to you about sex. But there's been a lot of research showing that even male patients that were on these therapies still had a lot of sexual dysfunction that was very concerning for them. So don't just assume their sex life is great because they're on tadalafil or they're on, sildenafil. So yeah, don't assume that's actually helping them at all in that area. But palliative care, yes, big fan.
So I would love to bring it up on the first visit, and sometimes I do, but the majority of the time I don't, because we cover so much. I just don't have the time. We're talking about a new disease state, and we're talking about what their goals are, and then we're talking about what I see in their disease state and what therapies we have available to change their physiology to then help them meet their goals. And so that first visit is just too much and too long for me to really dive into it unless it's just obvious that's where we need to go. And so it's usually that 6-week, 3-month appointment that I start to bring it up. And the way I approach it is, we've talked about what you've got going on. We've talked about the therapies we have. We've talked about your goals. And I always say, your goals are my goals. And so I'm going to be transparent and tell you what I see and what I have available that we can try to help you meet your goals. And then I say, there is also this specialty called supportive medicine or palliative care. And it is care for somebody with a chronic health condition. And then I say, so the 18-year-old with diabetes qualifies for palliative care. I try to make it like, you've got a chronic disease, you're not dying, but you need extra support. And so I say, we've got you on these therapies. We've got plans to continue different therapies and ways to go. But I think that this added benefit of a supportive medicine consult or palliative care consult can help see the whole picture. So if you're having side effects from our medications that, we've trialed and errored how to manage these side effects, but you still feel them off and on, and then you've still got side effects from your disease state that, we're trying to treat, this provider comes in with a different set of eyes that can see it in a different way and can help you manage these side effects while we still forge on and move forward with trying to manage and treat your disease state. And then I have to say, this is separate from hospice. And I have to put those words out there so that, one, when they leave and they talk to family, they know they can just repeat verbatim what I said, that this is not hospice, right? So that's kind of how I approach it. And I do wish I could approach it earlier, but I just think that when they're getting their first diagnosis, it's so overwhelming and there's so much to go over. But it is important.
So from that same kind of concept you talked about, the medications, let's maybe pivot a little bit and talk about how do we manage those the polypharmacy and those adverse effects of our medications. And in that palliative and the world that we live in PH, like I said, we're palliative or cardiology, pulmonary or psychiatry, psychology, and many other things to that patient.
Sex therapy.
Apparently that too, sex therapist, also is what she stated. So, so how do you approach that piece of it? What's causing what, and how do we manage that? And especially now, I think 20 years ago, we had very limited options. Now we have a whole lot more. And there's a whole lot more between ChatGPT, Patient GPT, and everything else online that they come up with their own methodology. So kind of talk about that polypharmacy and those effects and how we manage those conversations in part of that inclusive patientness.
Well, I think we all know that with pulmonary hypertension, just the symptom burden of the disease is very high in the amount of debility that the patient experiences. So when we add on polypharmacy and all kinds of competing drug side effects, generally I will try to mitigate those things with, of course, over-the-counter prescription methods. But, if I feel, which, back talking about when we introduce palliative medicine, back when I was young and full of ambition for those 40-minute slots, I was like, hey, I'm going to talk and have this conversation with every patient first visit. And I'll be honest, again, it's so many competing priorities in practice that I do tend to kind of prioritize patients where I think, palliative medicine can, that they're very bothered by their current symptom burden. They're coming to me with a lot of side effects of their disease already, that we may or may not be able to mitigate in the short term. Or if they have, let's say a CPFE patient comes into my clinic, or ILD, or someone who's been late diagnosed, you know that, they're probably on a trajectory where introducing palliative medicine, although it's not hospice, to get that train on that track sooner is going to benefit the patient. So I do try to prioritize it based on the patient's phenotype to some degree.
I totally agree with that. And I think we have such limitations in palliative care. The dream is that we have access for all. We do not have access for all. And I think home palliative care varies so much from formal palliative care from medical centers. And so I'm like you. I think it's case by case. Also, a new patient is coming to you as the referral center for this hope and this, so I don't generally do it first visit. Now, if they come in on 10 liters and they're ILD group 3 and comorbid conditions, that might be different. But we tell them we're always going to be honest with you. We're always going to be honest with you. We're going to make our best recommendations. And we use a lot of palliative care, I think more for the comorbids. The young 19-year-old that comes in that I just saw yesterday, by the way, she had the highest PA pressures we've ever seen in our whole life. I told you about her, December 19th. And she had her 6-month sotatercept cath this week, and she is rocking on quadruple therapy. So that would be one I'm not going to go palliative care. We're teaching her parents and everybody, we are going to make her better. She's idiopathic. So I think it's case by case, and we have so many limitations with access to palliative care. I think it's tricky. But they certainly can help us with polypharmacy. I think our team manages the vast majority of the pulmonary hypertension polypharmacy / antifibrotic, put that in there with, for all the ILDs who are on all these things with GI things going on. But
I agree. I find it difficult in our center. We have a pretty robust palliative care center at the Cleveland Clinic. But that being said, and raise your hand if you agree, but, a lot of our palliative medicine physicians are much more comfortable in the cancer space. And so, finding someone who has a specific interest in pulmonary medicine patients is difficult to find someone. I've been blessed moving into the heart failure space that we have a dedicated heart failure palliative medicine physician. And, that's something I hope to see become more and more common in pulmonary medicine as well.
So where we are, we have 2 fantastic palliative care providers that are well-versed in what we're doing, and they always call and make sure that, what's your goal with this referral? What do you want me to do? And then they do all their appointments virtual for the most part, which is really good for our patients that are located hundreds of miles away. But also with the polypharmacy, they can also come back and look at all the medications our patients have been prescribed. Be like, why are you on that? Is that actually helping, or are you just getting side effects from that? And then they can add medications. So one thing I like for the patient's fatigue, that I'm like, I don't know what else to do for that. They're adding like modafinil. I'm like, you take that on your license, you're good. I don't have to. So they can help kind of add to our polypharmacy to help with some of the side effects. And so when I have these patients in clinic, I know my medical assistant, they've already gone through all the medicines, but I go through it again. And I'm like, this, and I kind of compartmentalize the disease states as I do this, because I see patients with PH and ILD and PH-ILD and everything else that comes with being a human body, right? So I compartmentalize, and I'm like, okay, we're talking about these medications for heart failure, diuretic management. We're talking about your PAH medications, and then now we're moving on to management of the PAH medication side effects and that toolbox and what I want you to use. And so I really try to compartmentalize each disease state and make sure that the medications that we're actually talking about and recommending are still beneficial, and getting rid of the ones that we don't really need, that are just fillers, and trying to be intentional about when they leave the visit, they know they've got a comprehensive list and understand why.
I was almost today years old when I found out that not all palliative care companies practice the same as far as what they prescribe for patients. I assumed they all did benzos, for breathlessness in especially like our overlap patients with lung disease, and they do not. And so, as a community practice, every palliative company wants our business, right? They're all coming in vying for our business. One of the first things I asked them, I sound like a drug seeker, do you do benzos? Do you do benzos?
Benzos.
Because that's what my patient's breathlessness is so important to me. And our patients are very symptomatic at high elevation as well. And so, I have a list of palliative folks that will do that. And so, and I've had conversations with some of their medical directors about it that no, I'm not going to send you referrals because breathlessness is my number one concern for the majority of my patients that I'm sending you, regardless of the type of pulmonary disease. And so make sure you're having that conversation because they may not be getting drug therapies from their palliative care that you think might also help them that maybe you don't want to be responsible for, like benzos.
Another thing I think with palliative care that's so helpful is just that whole, we talk about with our patients all the time. This is such an invisible disease. Every clinician here is going to nod their head, what do you mean? You look absolutely fine sitting in the chair and, they can't walk across the room. And so I've found so many times where these patients are just in tears telling me how much palliative care helped their family understand severity of illness and limitations and just bringing, they can spend all that time that we can't to do everything. So pretty powerful.
So one of the things I've done when I've approached it earlier with the patients, I approach it like it's a treatment option. That concept of we can do this, and then don't forget you have this one other option, which is do nothing. Or do nothing more. And I find that tends to open it up in a different way. And of course, that's kind of that fine line between that hospice and palliative care type kind of conversation. But it allows the patient to kind of maybe take a different perspective and realize that it's them who gets to control that aspect of their life as well. And when the family's present, then I'll also bring into that it gives them, specifically on that hospice arm of things, really that, not really hospice, end of life planning, advanced directive. So like the thing I see the most, what do we all see patients struggle the most with at the end of life? The patient's struggling, and now you're turning to that wife, that son, that whomever, and saying like, what do they want to do? What do they want to do? And so I'll say, while you have it all within you to be able to make those decisions to help guide your loved one through that care, it is one of the most powerful tools you can give them, because what you don't want to leave behind is guilt. And I have found that to be very welcoming to them. I tell them, you don't need to make a decision today. If you look at those 5 wishes, you can write out your own letter to your family that helps them understand that. I share a lot of self. When my mom was going through it all my life, my mom was like, don't do this, don't do that. I don't want this, and don't do that. And then when we were there facing with her being very, very ill, and I'm like, Mommy, what do you want us to do? And she's like, her only line was, God is in control. Man, that wasn't an answer for me. That wasn't a, do this or do that. It wasn't direct, but I understood what she was saying, right? But it still was like very hard because nobody wants to be the one that says, I signed that paper saying do nothing else. And I think the only people who truly feel really confident is the one where they got that word from that family member who made the decision when they weren't in a moment of desperation, when they weren't in that moment where they were facing death. So, just bringing it up again, that they have some control and some peace, and that they would actually give the family the gift of their decision, I think goes a long way as well, too. So that's how I usually approach it with those early on patients, and have found that to be the most effective thing that I've ever done in that particular conversation that works. So that's my personal experience. Any other thoughts or comments around that?
I was just going to say I 1,000% agree with that. I think we have to remember that we're dealing with people in their families, and family dynamics are complex, right? We're walking into these people's lives on chapter 60. We don't know what they've come through or what their family background or history with death and dying is. So sometimes they get this kind of from their doctors or their Facebook groups or this kind of like cancer fighter mentality that you don't have permission to talk about what if else, right? So I think giving them that permission and that space for them and their families to talk about it is incredibly meaningful.
And using that line that you guys know I got a palliative care certificate because I do so much this, which was amazing. But the line in palliative care, we can use this for sex talk. We can use it for palliative care talk. Would it be okay if I share some things that other patients have told me in this situation? That is such a powerful thing to say, to open it up. And I feel it works really well to start some hard conversations.
I also say, I want to talk about this now before we have to talk about it. Let's, and I said, this is scary stuff. It's all scary, but I just want to plant the seed and start the conversation. You don't have to make a decision, unburden them to make a decision. You do not have to make a decision today. I just want this to be something that you think about, because I know you're thinking about dying. We all think about dying. I don't have as far as I know, I don't have a terminal disease right now, but I think about dying, and it's natural. We all do. So I try to unburden with that, but you should, start having these conversations with your family. Do you talk to your kids? Do you talk to your spouse about, your plans and what you want? Do you know what you want? These are people that also, the palliative care folks, these are also people that can really help you outline those goals and what do you want to do. And so we don't have to spend a lot of time during the visit to really go through like their exact wants and what they want to do. But just, I tell them, do you know why a scary movie is scary? Because you don't know what's in the basement. You don't know what's around that corner, right? This is life's jump scare, right? When they have these terminal illnesses. And I tell them that, I'm like, that's why scary movies, I don't want this to be scary. Let's try to make this as least scary as possible. This is the path we're going to take. These are the steps that we're going to do. You're going to know everything we're going to plan for. And that is the end. That's the end for all of us. And so this is something that you should at least start thinking about. And hopefully it's years from now and I retire and you get somebody else to take care of you, and this is nothing I'm going to have to see you through, but let's just be prepared.
I usually, again, try to normalize everything. And so I'll tell patients, none of us make it off this earth alive. And so we have to plan. Everybody does. And that's usually how I kind of open it up.
We started doing a once a year support group on advanced care planning. We have a palliative care nurse practitioner do it. And I want to do it nationally. It was so well done. So she did that. And then she did tips for living with dyspnea and fatigue, which is like our patients' everything, right? And it was so outstanding. I really want her to do it nationally. But how engaged these patients were on all the advanced care planning was amazing. It was, we don't have time in clinic to do that either,
Very true. So we have a good little bit amount of time left, not a huge amount of time, but I think it's really important that we add this last component here. And this really kind of talks about what you're really driving into is having these conversations with this unique population of patients. And how many in this room are PH providers? Like actually, you do quite a bit of it, right? And when you say to someone, I take care of somebody with pulmonary hypertension, what response do you get? I'm going to ask you, Starless. You're sitting right there and you started this as a nurse and I know your name and, I like to call people out, right? Right? They have no idea. Or you get the people who might have an idea. What's the other answer you get? Oh. How do you do that, right? That feels like oncology.
None of us have any idea. We just do it.
Right? So
Thanks for asking.
Right. So, I'm down to the point where I have my PH support group, which is for me as the provider, right? So we have this little chat where there's a group of us, you exchange all kinds of stuff, but it becomes your support group, the place that you can vent. So I want to kind of wrap this up with, I'm going to give you guys an opportunity to ask questions of us as well, but kind of just share, what is your perspective as being the most challenging aspect of being a PH APP?
We might need a few hours.
Do you want me to go first as the person who openly had burnout last year? I think being a PH provider, you're uniquely poised for burnout because of the relationship that you have with these patients. It's a very deep, intense relationship. You're longitudinally managing them through some really scary stuff, and it's difficult. You're having conversations that are emotionally draining, mentally taxing as a provider, in very difficult circumstances to practice in healthcare currently, right? And, raise your hand if you leave work on time.
man.
Great. That's nobody.
Oh, we got one. We got
Oh,
one.
we got one.
Perfect. Good.
We got one.
So you deserve a round of applause because one person got it.
So the next session will be life hacks from you because
We're going to add you to the panel. Mm-hmm.
yeah. So, it's very difficult to take care of these patients. And I think it's difficult to work in healthcare as well. But, we were talking earlier, some of the kind of key things that led to my burnout was the difficulty of being a single advanced practice provider for a very large program. That it's difficult. We're not the most money-making enterprise in the hospital institution. So they're not, just handing out FTEs like Oprah Winfrey.
Mm-hmm.
So, oftentimes you're the one person for that institution. You're the expert. You are the knowledge of all PH repository, whether, even as an APP, whether it's how to get a prior authorization, how the heck does this pump work, or, diagnosis in treating patients. You run the gamut of being that source of knowledge and that first person that people are going to reach for, right? And I get it. A lot of the physicians we work with are wearing a lot of hats, and sometimes it's easier for us to be that go-to person, like, hey, Mrs. Jones, like, needs this. I don't know how to do it. Figure it out, but it's very taxing as a space to be in, and I think really, really lends itself to burnout. And I'm sure that other complicated pulmonary medicine patients do as well. But it's, the biggest thing for me in leaving the PH space primarily and moving into heart failure was because of the relationship you have with patients. You might meet them in the ICU crashing and burning, where you're the first person to walk in after the cath and give them heartbreaking news, right? And work through that, phase where they're like Charlie Brown's teacher voice, just nothing's going in, to actually functionally managing their illness over time. And, it's celebrating the wins as they improve or mourning the losses if they don't. You develop those relationships. And so the idea to step back or to institute any boundaries of work-life balance are really, really hard. There's a lot of guilt involved in that, right? As PH providers. So I wish I had an answer. I don't suggest that everyone,
Don't leave the space.
pivot their careers.
Right.
But I think it's something, these conferences kind of become your support group, your touch base with other providers, because we're all kind of siloed and just heads down, just working like crazy. And so, my hope is that within the PH space that we build an opportunity more for a PH provider support group,
Mm-hmm.
to help address these issues of burnout, just coping with this, caring for this patient population.
Mm-hmm.
So,
So until I have just like 2 minutes, and then I'll be able to ask a question or two. But so just really, what are some things you've done to manage that emotional burden of the longitudinal care of that patient? So Susie, you've been at it for 28 years.
tell us your secrets.
No, I don't have secrets. I do remember 10 years ago, I came back to clinical care. I had a stint in industry. And I remember coming back to Val McLaughlin first month of work and saying, Val, they still die. She said, yes, Susie, they still die. And I think that, this emotional burden, it's a love-hate. Obviously, we're people that like chronic illness and like the patient relationship and the patient story and the whole person. And at the same time, those are the most taxing patients and can be so hard on us. So mine is definitely my support group. Every one of you, all of you, my people, just lifting me up, making us all better, making us take the best care of patients, watching the wonderful progress in this disease. And, I tell people, I help people live, and sometimes I help people die, and that's beautiful.
That's right.
So, yeah, but I don't have an answer either of not burning out. We all work too much.
Yeah. One of the first PHA conferences I was invited to speak to, I don't know why I was invited, but I was, and then I rambled on a little bit, but I made a comment that I kind of sat back with me too, but we were talking with patients, and I was like, when you're a PH patient at a center, you essentially have an MDVIP, and like, that's how we care for our patients. Like, they have an MDVIP without having to pay that MDVIP cost, right? And then, so I think about that because that's the service we provide. But then I also think about us up here. We're nurses. For some reason, we've been called to a profession that cares for patients in the way that we do. Not that any other profession is different, not that our physicians are different, but I think our hearts are just built different. And so we do tend to own some of that patient's burden and we take that on. And so I've just had to have some time for myself to recenter my thoughts and remind myself that I do still care for them a great deal, but it's also not my heart to own that as much as I do. And so having a debrief, kind of like we do at the ends of codes and things like that in the hospital, but making sure I have my debrief at the end of the week or something that says like, okay, Lori, you've done everything you can. Your patients know that you've done everything you can. And now that is it. And that is good. And that's enough. And then I go to my husband who can't even hear me talking about putting an IV in or something. And I'm like, so, okay, I'll get dinner. We're good. Right. So that and personal support group for our providers. Like that's important.
Your outlet, Corinne, what's your outlet?
I try to live life outside of work. I work a lot. I do a lot of things, but I really try to, when I'm not at work, I'm not at work, and really try to forget I know anything about medicine. And I just try to live life as much as possible. And my faith definitely helps. If you have not gotten into Stoicism, it is fabulous to help you with life in general. These Stoic philosophers just do such a great job of there is you, there's what's happening around you, and they are totally two separate things. And it really does help you, not take on those burdens on your own heart. So Stoicism.